Okay. I guess I was on mute as well. So for those at home, I apologize for missing the first part of this discussion. So this schematic really offers an overview of the management of lower risk MDS. And what's key is that for asymptomatic patients, and I'll explain this as well, because I don't know if you can see all of this with the screen so small. But in asymptomatic patients, they don't need treatment. We can monitor and follow blood counts every 3 months until symptoms progress. For symptomatic patients, the treatments are aimed at improving the cytopenia involved. So for isolated thrombocytopenia and isolated anemia, all patients will get supportive transfusions if needed. For patients with isolated thrombocytopenia, we can consider treatment with thrombopoietin agonists, eltrombopag and romiplastim. For isolated anemia, the first-line treatment for deletion 5q MDS is lenalidomide, and for those without deletion 5q, I will talk about that now. Additionally, for isolated neutropenia, we really don't treat with G-CSF unless there's recurrent or resistant infections with severe neutropenia. For multilineage cytopenias, if there's this can potentially be an overlap with aplastic anemia, PNH, and other LGL. And so if there's a hypocellular marrow, a PNH clone, a STAT3 mutant clonality, these findings suggest response to immunosuppressive therapy treated with ATG, cyclosporin, and Promacta. But if there's low probability of responding, they should receive hypomethylating agents and transplant referral. So next, I'll really talk about deletion 5q MDS, treatments and advancements. Actually, sorry, first we'll talk about supportive treatments with iron chelation therapy. So iron chelation therapy is recommended by the NCCN guidelines if you have 20 or more 20 to 30 red blood cell transfusions received. You can consider daily chelation with deferoxamine or deficerox to decrease iron overload. This is particularly relevant for patients with low-risk MDS, lower intermediate risk MDS, and who are potential transplant candidates. And the goal, if patients have ferritin levels greater than 2,500 nanograms per ml, to aim to decrease ferritin to less than 1,000. The toxicity with these agents is renal failure, and so having kidney impairment does, with a creatinine clearance less than 40, can make treatment with these agents difficult. So these are the toxicities of iron chelation. Renal toxicity, hepatic toxicity, and GI hemorrhage are black box warnings, which the FDA says is of utmost importance. Diarrhea, nausea, abdominal pain, and skin rashes are also relevant. Sorry, so now I'll talk about management advances in deletion 5q MDS. So lenalidomide is FDA approved for transfusion-dependent anemia due to lower risk MDS with deletion 5q, and this was approved in 2005. The recommended initial dose is 10 milligrams daily, days 1 through 21. And this is based on seminal clinical trials showing high rates of red blood cell transfusion independence, and that this red blood cell transfusion independence was really quite durable, lasting more than 2 years for patients on these agents. It also induces cytogenetic responses, 50 to 73% of patients having complete or partial cytogenetic remissions. These are the lenalidomide-associated toxicities. Embryo-fetal toxicity and venous thromboembolism are the black box warnings. And many patients should be at least on aspirin or another anticoagulant if they're on these agents. The other toxicities include thrombocytopenia, neutropenia, diarrhea, rash, and fatigue. The mechanism of lenalidomide has recently been revealed by Ben Ebert and colleagues. Lenalidomide serves as a molecular glue, it's specifically taking substrates and linking them to the E3 ubiquitin ligase, to cereblon, and degradation by the E3 ubiquitin ligase. This is relevant because because casein kinase 1 alpha, the gene is on chromosome, the long arm of chromosome 5. So patients with deletion 5q have only one copy. And so when they receive lenalidomide and undergo casein kinase 1 alpha degradation, it leads to synthetic lethality and death. And in contrast, patients with and then normal bone marrow stem cells have two copies of this gene and are spared. And this underlies the increased responses that we see with lenalidomide and deletion 5q MDS. A really interesting trial recently was presented at ASH called the Sintra-Rev trial. And this trial really is interesting because it evaluates earlier introduction of lenalidomide earlier in the disease course for patients with deletion 5q MDS. So this is a phase 3 randomized placebo-controlled trial, patients with low-risk MDS with deletion 5q and anemia, but not transfusion dependent. So the treatments were lenalidomide at a lower dose, so the 5 milligrams per day continuously as opposed to 10, versus placebo. And the primary endpoint was time to transfusion independence. The secondary endpoints are listed below. So this trial met its primary endpoint. The time to transfusion dependence from the beginning of treatment was about 5 years, over 5 years, so 66 months compared to 11.6 months. The event-free survival, again, 60 months compared to 20 months. Complete cytogenetic remissions occurred in 70% of patients. Hematologic improvement occurred in 70% of patients with no increased risk of AML evolution. And notably, many of these patients had P53 mutations. Some of patients had P53 mutations, which are associated with resistance to lenalidomide, and there was no increased risk of AML evolution among those patients. So next, I'll talk about the non-deletion 5q population, patients who have ring sideroblasts or SF3B1 mutations, and those who do not have ring sideroblasts or SF3B1 mutations. So what are ring sideroblasts? I've talked about them a lot. And you can see that the ring sideroblasts are these little blue dots on iron staining right here. So these are erythroid precursors with iron deposited in perinuclear mitochondria. And this can be due to non-clonal causes, alcoholism, drugs, in particular isoniazid, lead toxicity, copper or pyridoxine deficiency, or congenital sideroblastic anemias. And it can also be due to clonal causes, in particular MDS with ring sideroblasts and MDS and a myeloproliferative neoplasm overlap. So it's typically, what's remarkable about this category is that SF3B1 mutations are found in over 80% of patients with ring sideroblasts. And it's associated almost uniformly with low risk of AML transformation. And anemia, isolated anemia with thrombocytosis in the cases of MDS-MPN overlap disorder. So the management of anemia with non-deletion 5q, I would say a significant advancement has been luspatercept. So luspatercept is a ligand trap that neutralizes transforming growth factor beta to really promote terminal erythroid differentiation. The initial dose of luspatercept is 1 milligram per kilogram every 3 weeks, and it may be increased to 1.33 milligrams and 1.75 milligrams per kilogram. This is important because most of the responses occurred at the higher doses. So in the community, we're trying to emphasize that you have to go up on the dose before you discontinue. The FDA approved luspatercept for transfusion-dependent anemia after failure of erythropoietin-stimulating agents in lower-risk MDS with ring sideroblasts or with MDS and myeloproliferative neoplasm overlap with ring siderosis and thrombocytosis in 2020. And then subsequently, the FDA recently approved luspatercept as frontline for anemia in erythropoietin-stimulating agent naive adult patients with lower risk MDS who may require regular red blood cell transfusions. That is the maximum dose. Yeah. Yes, I'll show that next. So that luspatercept, it really is an interesting drug. So normally, transforming growth factor beta leads to excess GDF11 and terminal, basically an arrest and terminal differentiation of red blood cell development. And luspatercept takes the TGF-beta receptor and has it attached to an antibody so that it works like a sponge and essentially soaks up all the TGF-beta to allow terminal differentiation of erythroid development. The seminal Medalist trial was a phase 3 randomized placebo-controlled trial. It has IPSS-R very low, lower intermediate risk. It included patients with ring sideroblasts, at least 15%, or 5% with an SF3B1 mutation. And these patients were refractory, intolerant, or unlikely to respond to erythropoietin-stimulating agents. They also were transfusion dependent. The treatment was luspatercept, 1 milligram per kilogram every 21 days versus placebo. And the primary endpoint was transfusion independence for 8 weeks or longer during weeks 1 through 24. And below are the secondary endpoints. And so this trial met its primary endpoint. So to your point, 38% of patients were transfusion independent for at least 8 weeks, compared to 13% in placebo. And the erythroid response was also impressive, 53% versus 12%. 70% of patients in the luspatercept group had a mean increase in hemoglobin greater than or equal to 1.5 grams per deciliter. And the median duration of transfusion independence was around 30 weeks for luspatercept, compared to 13.6 weeks for the placebo. After this agent was approved for relapse refractory low-risk MDS, it then moved to the frontline setting in the COMMANDS trial. This was a phase 3 randomized placebo-controlled trial, again, low risk by IPSS-R, transfusion dependent. These were patients were erythropoietin-stimulating agent naive and included, they had to have been sensitive to erythropoietin-stimulating with an EPO level less than 500. So the treatment was luspatercept, 1 milligram per kilogram every 21 days, versus epoetin alpha, which is an erythropoietin-stimulating agent, 450 international units per kilogram weekly. And the primary endpoint was it was a 2-part endpoint, so more stringent. It was transfusion independence for at least 12 weeks and a mean increase in hemoglobin greater than 1.5 grams per deciliter. And so the primary endpoint was met in 59% of patients with luspatercept, compared to 31% of patients with epoetin alpha. The transfusion independence at 24 weeks was 48% luspatercept versus 29%. The time to erythroid response was shorter. And this is really impressive. The median duration of transfusion independence for more than 12 weeks lasted over a year and a half and was twice as long as epoetin alpha at 31.75 months versus 19.25 months. But subgroup analysis really showed created some controversy in determining whether luspatercept was beneficial for all or for some. And we see that ring sideroblast patients were super responders to this therapy. The primary endpoint response was 65% versus 26% in epoetin alpha. And the same is true for SF3B1 mutated patients, 70% and 31%. However, for those without ring sideroblasts or without an SF3B1 mutations, there was no significant difference between the first line epoetin alpha. Um, um, Part of this may have been due to the small numbers of patients who were ring sideroblast negative. It was lower than they had expected in the protocol. It is worth noting that they did observe a longer duration of transfusion independence. However, this did not reach significance with luspatercept, but this did not reach significance due to the small numbers of patients. There are other subgroups that typically don't respond to the epoetin alpha that did respond to luspatercept. Patients with serum EPO levels 200 to 500 were more likely to respond to luspatercept, and patients with high transfusion burdens, more than 4 units over 8 weeks, were more likely to respond to luspatercept. So this was a significant progress in our field and led to the upfront approval of luspatercept. Luspatercept toxicities included fatigue, dyspnea, peripheral edema, diarrhea, nausea, dizziness, and hypertension. The fatigue and dyspnea are also anemia-related symptoms, but it tends to improve with time with luspatercept. So another soon-to-be advancement and probably likely an FDA approval in our field is imetelstat. So telomerase protects the ends of chromosomes during cell division to enable immortality in cancer cells. Imetelstat binds the RNA template region of telomerase to inhibit telomerase activity. So basically, it's a 13-mer oligonucleotide linked to a lipid tail that covalently binds, irreversibly binds that RNA portion of the telomerase to inhibit it. So imetelstat kills MDS cells with high telomerase activity, but spares the normal bone marrow cells. And so this was the seminal eMERGE trial. This is a phase 3 randomized controlled trial. Again, lower risk MDS by IPSSR, patients who were relapsed or refractory to erythropoietin stimulating agents or unlikely to respond. It also, they were transfusion dependent, at least 4 units of red blood cells over 8 weeks, and no prior treatment with lenalidomide or hypomethylating agents. The treatment was imetelstat, 7.5 milligrams per kilogram every 4 weeks compared to placebo, and the primary endpoint was 8-week red blood cell transfusion independence. And so the primary endpoint is on the far left, and it was met with 40% of patients attaining transfusion independence compared to 15% in placebo. And the responses were quite durable. Even at 1 year, 18% of patients were still transfusion independent compared to 2% for placebo. And this also illustrates the durability of these transfusion independence, a median of 51.6 weeks of transfusion independence compared to 13.3. Again, highly significant. What was really impressive was there was a very high increase in hemoglobin among patients receiving imetelstat. There was a median change in hemoglobin of 3.55, and so patients had a peak median hemoglobin of 11.25 with imetelstat compared to 8.85 for placebo. It's also encouraging that we did see responses in both the ring sideroblast and the non-ring sideroblast population, and in patients who had high transfusion burdens. You probably can't see this slide so well with the small screen, but I'll explain it. Basically, imetelstat led to a reduction in the mutational burden, suggesting that it may be disease modifying. So it's actually reducing the disease clones with response. The imetelstat toxicities were thrombocytopenia and neutropenia. These were the major toxicities, but these were transient and typically resolved by the end of the cycle. So next I'll talk about thrombocytopenia. So thrombopoietin is a platelet growth factor. Thrombopoietin binds the thrombopoietin receptor on megakaryocytes, but it also binds stem cells, hematopoietic stem cells, and promotes maturation of megakaryocytes. So there are several thrombopoietin mimetics or agonists approved for immune thrombocytopenia, romiplastim, eltrombopag, and Promacta or avatrombopag. Eltrombopag is also approved for aplastic anemia. And so platelet transfusions in MDS are costly, there's limited supply, and there's really, with repeated transfusions, an increased risk of alloimmunization or developing antiplatelet antibodies. And so there's a need for platelet improving agents. This is a large randomized phase 2 trial with romiplastim in lower risk patients with MDS, platelet count less than or equal to 20,000, or those with platelets less than 50,000 with a history of bleeding. It evaluated romiplastim versus placebo, and the primary endpoint was clinically significant bleeding. And the trial did show that there was a trend towards a decrease in clinically significant bleeding, and in fact, for patients with platelets less than 20,000, it met significance, and there was an improvement in platelet response. However, the trial was discontinued prematurely due to transient elevations in peripheral blast counts. So they were 15% versus 4% blasts. However, this is transient, and so when the therapy was stopped, the blasts went back to baseline. And we see that there was no difference in death or risk of developing AML over time, and actually the survival outcomes were very similar. So this recent trial, the EQUAL MDS trial, was important just to help clarify the safety of these agents. So this is a phase 2 randomized placebo-controlled trial evaluating lower risk MDS patients by IPSS, platelet count less than 30. And importantly, in contrast to the previous study, they excluded patients who had 5% or more blasts. So eltrombopag was dosed at 50 milligrams daily and titrated up to 300 milligrams daily versus placebo. And the primary endpoint was a platelet response and really this long-term safety and tolerability. So the platelet response for eltrombopag was 42% compared to 11% for placebo, and this reached significance. The rates of clinically significant bleeding were lower in the Promacta arm, and the risk of AML transformation was not significantly increased. The eltrombopag toxicities include nausea, fatigue, fever, elevated liver enzymes, diarrhea, and the black box warning is hepatic decompensation in those with hepatitis C. So now I'll talk about management for patients who are refractory to these first-line agents. This is an older study. This is a phase 3 trial evaluating lenalidomide in non-deletion 5q MDS. And the mechanism here is that it promotes erythroid responsiveness. So it's, as opposed to the casein kinase 1 alpha degradation. The population was lower risk MDS, non-deletion 5q. They were refractory or ineligible for erythropoietin stimulating agents. They were transfusion dependent, and the treatment was lenalidomide 10 milligrams daily versus placebo, and the primary endpoint was red blood cell transfusion independence, lasting 8 weeks. Lenalidomide versus placebo was 27% versus 3%, and the duration of red blood cell transfusion independence was around 31 weeks. So this is the reason why lenalidomide is considered in non-deletion 5q MDS patients. So IDH inhibitors in myeloid malignancies, there are 3 IDH inhibitors, ivosidenib, enasidenib, and now olutasidenib. The mutations of isocitrate dehydrogenase 1 and IDH2 lead to production of a cancer-causing metabolite. It's called 2-HG, 2-hydroxyglutarate. And 2-HG leads to an arrest in differentiation and leukemia. So IDH inhibitors halt the production of 2-HG, leading to differentiation of leukemic cells. And that's what makes this so promising in MDS. We're not just killing leukemia cells and normal cells. We're differentiating the bad cells to normal cells. So we're making these cells differentiate from leukemic cells or MDS cells into normal cells and improving the counts. So IDH1 inhibitors were approved for relapse refractory IDH1 mutant AML, ivosidenib in 2018, olutasidenib in 2022. The IDH2 inhibitors approved for IDH2 mutant AML was enasidenib in 2017. And recently, we have received approval for MDS. So ivosidenib has been approved for relapse refractory MDS. But the prevalence of IDH1/2 mutations in MDS is lower than AML, only about 5% of patients. So in a phase 1 trial of the IDH1 inhibitor, ivosidenib, it included MDS patients relapsed or refractory to hypomethylating agents or intensive chemotherapy. The treatment was ivosidenib 500 milligrams daily, and the primary endpoint is a safety endpoint. Secondary endpoints were responses. There were 16 patients enrolled. Overall response rates were impressive, 81%. Complete remission rates were 44%. Hematologic improvement was seen in 69%. And red blood cell and platelet transfusion independence lasting 8 weeks occurred in 71% of patients. So these agents have been approved for MDS and are important for patients who have those mutations. Okay, so this is this is in general the most recent advances. There are I tried to focus on the agents that are likely to be FDA approved and change the standard of care. We have other investigational agents that are also promising, and I've listed some of them here. In addition to TGF blockade with luspatercept, we have a Keros drug as well. And then there's also evaluating luspatercept in combination with erythropoietin-stimulating agents and lenalidomide. We talked about imetelstat. There's a pyruvate kinase inhibitor. It was found that MDS cells activator. It's found that MDS cells have low levels of pyruvate kinase, and this drug can potentially improve that pyruvate kinase activity. And then roxadustat is a HIF alpha PHI inhibitor. So it's been evaluated in phase 3 trials as well. I tried to say if it was anemia oriented or all three. I think the targeted inhibitors are so promising because they target all the cell lines, right? So anemia, thrombocytopenia, and neutropenia. We have IDH inhibitors, and additionally, we have several splicing inhibitors that are on the horizon as well. It's relevant because splicing mutations occur in over 50% of patients with MDS. With that, I would like to say thank you for your time. If you have any questions, I'm happy to answer them. Thank you.
Did you say that for isolated neutropenia, growth factors are less commonly used now than in the past?
I would say that, yes.
Why is that?
It's mainly because having the low neutrophils is not necessarily a risk for infection. And so we only, and there can be risks associated with treatment as well. You can get splenomegaly, splenic rupture. It's also quite expensive. And so with Neupogen for neutropenia, we typically only are giving it for patients who have recurrent infections or who are at risk for who have resistant infections. We also use the Neupogen with erythropoietin-stimulating agents to improve the erythropoietin-stimulating agent activity. Often among patients who have had prior erythropoietin-stimulating agent use, adding Neupogen can salvage some responses. Yeah, it's an injection, IV, intravenous. Let me pull back. So it was given once every 4 weeks. Yeah. So just a one-time IV. Not yet. Thanks.
During your time and expertise with us today. Our next session will start in about 15 minutes. At 15, we'll be back in this room for the high-risk MDS session. So if you need to use the bathroom, we'll check out our sponsor table, but we'll be back in here. Thank you.